Dr. Narayana, working as a consultant in the Department of Uvea and Ocular Immunology. COVID vaccines were developed to protect us against the COVID infection by primarily inducing viral neutralizing antibodies. However, it was not without its unintended adverse effects. The vaccination trials did try to have detailed evaluation of the immune responses to the vaccines because safety was critical. However, after the widespread vaccination, post-marketing surveillance reported growing occurrences of post-vaccination ocular inflammation. So this is a retrospective case series of hospital data from a tertiary eye care center over a 3-month period. The study population was those patients who presented with ocular inflammation following COVID vaccination, where the symptoms arose within 8 weeks of vaccination and had a minimum follow-up of 3 months. The data collected included demographics, vaccination details, ocular history, and treatment and outcomes. The ethical committee approval was obtained and statistical analysis was performed. We had a total of 67 eyes, 56.7% were males. The mean age was 43 years and onset was noted to be about 25 days. Bilateral involvement was noted in 43.3% cases. It was noted that over 70% patients presented with symptoms within 1 month of vaccination. Our patients received one of 4 vaccines, that is the Covishield, which is a spike protein subunit vaccine, or Covaxin, which is a whole inactivated viral vaccine, Sputnik, which was a viral vector vaccine, and Pfizer, an mRNA vaccine. 56 patients, that is 83% of our study population, had received the Covishield vaccine, followed by Covaxin, and only a small proportion of the patients had the Pfizer and Sputnik vaccines. We noted de novo or first-time inflammation in 42% patients and recurrence of previously present inflammation in 58% patients. Interesting was to note that after the first dose we had more of de novo inflammation, and after the second dose we had more of recurrence of the previously present inflammation, possibly because of the booster effect of the vaccine. Coming to anatomical classification, majority of the patients had anterior uveitis that was about 42%, followed by panuveitis, but we did not find any statistically significant association between the type of vaccine and the anatomical diagnosis. In etiological diagnosis, we had again a major chunk of patients, that is 46% with idiopathic inflammation, but autoimmune related diseases were encountered in 31%, and an infectious etiology was found in about 23% patients. There was a statistically significant association between vaccine dose and the etiological disease, and this may suggest that on further booster dose, some of the vaccines may trigger inflammation to cause a specific etiology of inflammation, such as viral or even idiopathic. After the first dose, the most frequent etiologies was idiopathic, also IgG mucoviscum and viral uveitis. After the second dose, there was a significant increase in the number of idiopathic cases. Viral reactivation was noted in both the subgroups. Treatment was conventional with the use of corticosteroids and immunosuppressive therapy based on the severity of inflammation or the type of etiology. And most of the patients had good visual outcomes, except for those with cystoid macular edema, choroidal atrophy, optic atrophy, or acute retinal necrosis. The ocular inflammation mechanisms is still unclear, and the hypothesized pathways involve both the adaptive and innate immune systems, including molecular mimicry, T-cell response, and cytokine production. Potential triggers will also be due to the adjuvants used in vaccine preparation. Similar to other studies published at the time, we had patients with majority with anti-uveitis. However, they noted a mean onset much earlier because they studied patients within only about 2 weeks of vaccination, and there are multiple reports of viral reactivation after their vaccination. The retrospective design on a small sample size make it difficult to establish a definitive causative relationship between the vaccine and ocular inflammation. Nonetheless, the clinician should be vigilant about the possibility of this, and even though the causality is only speculative. Our study offers valuable insights into the common and rare ocular inflammatory complications post-COVID-19 vaccination, enhancing recognition of vaccine reaction patterns, and understanding this immune dysregulation and the possibility of ocular inflammation post-vaccination will help in vaccine safety monitoring and immunization strategy in adults. We had tuberculosis and Uvea.
Like serpiginous choroiditis is a very common finding that you see after vaccination, which I noticed you did not have.
Yes, we had tuberculosis. I reported as TB SLC and treated called the TB category.
TB. And another thing, how long did you follow up these patients? Did you see recurrences in these patients again? Like how long was your follow-up of these patients after you started treatment?
So as per the study, the patient needed a minimum of 3 months follow-up, which was sufficient to tackle the recurrence or the removal inflammation. Within 3 months we could understand the outcome for the study. But yes, there were 2 patients who had reactivation after the second dose as well, as I mentioned in one of the slides.
No, what I meant to ask you was a late recurrence. Like once you've treated these patients, did you see the recurrence coming in again after a few months? How? That's what I wanted to know your follow-up. Did you follow them up?
Not in the study, but yes, in the sense that these patients, their immunosuppressive therapy was heightened after the vaccination, so probably they wouldn't have had an immediate recurrence noted on follow-up.
There are some criteria which are there to establish causality. So did you look into those criteria, because it could just be a coincidental finding that COVID vaccine, because at that time everyone was getting COVID and everybody was getting COVID vaccinations. So do you know anything about those criteria? Various studies have reported various criteria for establishing causality of.
Also, but our number and also the subgroup numbers were very small to establish, and even if we put anatomical classification or ecological classification, the numbers were very small to go into to establish causality.
There are some very good studies by the Carlos Covezio group, one in 2022 and one in 2024, and where he has delved into the causality of hepatitis post-COVID vaccination.
So they have the MX1 and TH1 and TH17 pathways, which one is for the viral reactivations, which is more common, and also the TB is explained with the TH17, but we did not have. This was done actually in the first half when the vaccination had started and we saw patients coming in. So I think ad hoc analysis will help us.
After the first dose. So were they advised not to take the second dose?
Yes, ma'am. We did not say not to take the second dose, but we were very speculative that they may get a recurrence, and we did call them out for a follow-up, but they did not have the patients in our study did not have. Only 2 patients had inflammation after the second dose as well. The other patients did not.
You called up the patients after?
Yes, we asked them. Yes. We had problems on the review after the, because they did ask us, can we take the second dose, and there was no at that time systemic management and safety from COVID was more critical than the ocular inflammation, because again majority of our patients had only anti-uveitis and they all had good visual outcomes except for the macular pathologies and optic atrophy. So we did not tell anybody not to take vaccine.
So they all responded to the topical therapy?
No, ma'am. Depending on the etiology, we did treat them like whom we diagnosed with TB, uveitis, we treated them with LGT, and viral uveitis, all of them, the patients with AR received intravitreal calcium removal, and the anti-segment inflammation keratinouveitis or only anti-uveitis, we give them oral valsectomy.
So what was the recurrence? Especially in AR and ALS?
No, I think the patient with AR did not take his second dose. It was an elderly patient with poor outcomes. So I think he did not take the second dose, and he said he will he deferred the second dose by himself.
No, it's not only about the dose.
Okay,
but you can see recurrences or even in the anterior uveitis.
No, ma'am.
We are just speculating that this is because of the COVID only.
Yes, no, ma'am, we did not have recurrences, and possibly that is why we included these as an idiopathic only post-COVID vaccinations. We did not find any etiology and did not have any recurrences. Yes, as per the study, within 3 months,
3 months
Sorry,
is not a period
I
for,
can-
you cannot say that the patient had no recurrence.
So then
Yeah.
Also, did you take into account like COVID, infection? Like, did you factor in whether the patient had, apart from the vaccination, prior COVID, infection? Because there are major studies from the UK, population-based studies, in which they found there. Did you measure anti-COVID antibodies in these patients?
yes, so that
You did.
but not in the true sense of anti-COVID antibodies, but patients who had had COVID within 3 months were not eligible for the vaccination at the time as per the rules. So
Yeah.
none of the patients had COVID within 3 months. So only bias would be if a patient had received the vaccine and then also had a COVID infection.
So there were major studies from the UK in which they have shown that if there was a prior COVID infection, in those people, the antibody levels which were they checked were very high compared to those who had not had the infection. So post-vaccine, even the first dose of vaccine, if they had prior COVID infection, their antibody levels were much higher. So those studies are very important when you are kind of analyzing this kind of uveitis. So look into that as well.
So definitely for the future studies, probably we should guide the management that prior to receiving the vaccination, antibody assessment